Welcome back to the deep dive. Today, we're really getting into something quite common, but also, well, pretty complex in the horse world, equine anemia. We've pulled together a lot of detailed info, focusing specifically on the pathophysiology, diagnosis, and treatment. Our goal here is to really unpack it for you, what anemia is in horses, how you might spot it, why diagnosing it can be uniquely tricky in them, and how it's treated. Basically, a shortcut to getting up to speed.
Yeah, and it's so important to remember right off the bat, anemia itself isn't the disease.
Right.
It's a sign, a signal that something else is going on underneath.
Okay, a symptom.
Exactly. Understanding why it's happening is key. The complexity is really in figuring out that underlying cause.
Right. So let's start there. What's the sort of fundamental definition? What are we actually talking about with equine anemia?
Okay, so at its core, anemia in horses means you've got a decreased number of red blood cells, erythrocytes, or less hemoglobin packed inside those cells. Clinically, we measure this usually as a drop in the packed cell volume. That's the PCV, or the red blood cell count itself, or the hemoglobin concentration.
And the main problem that causes is...
Oxygen delivery.
Right.
Fewer red cells or less hemoglobin means the blood just can't carry as much oxygen to the body's tissues. That leads to something called tissue hypoxia, lack of oxygen.
Okay, so it's an oxygen supply issue. Got it. And what are the big picture ways a horse ends up in this state?
Well, there are really three main routes, three mechanisms. First, the horse could be losing blood hemorrhage. Second, its red blood cells might be getting destroyed too quickly. That's hemolysis.
Right.
And third, the bone marrow just isn't producing enough red blood cells, or maybe the ones it's making aren't effective.
You know, something that always fascinates me about horses is their blood physiology. Their red blood cells live for ages, right? Like 150 days.
Yeah, around 145 to 150 days. Much longer than many other species.
And then there's the spleen. The fact it can contract and suddenly boost the circulating red cells by, what, up to 50%? How does that play into thinking about anemia?
Oh, massively. That long lifespan means anemia, due to poor production, creeps up really slowly. The horse compensates. And the splenic contraction, yeah, that's a huge factor. A stressed or excited horse can squeeze its spleen and push a ton of red cells into circulation. Can totally mask mild anemia on a single blood test.
Wow. So a vet check after a trailer ride might give you a false normal.
It definitely could, yeah. Or make mild anemia look less severe than it really is. That's why, sometimes serial testing, looking at trends, is so important. It helps see past that splenic effect.
That's really crucial context. Okay, let's break down those three mechanisms you mentioned, starting with blood loss. Seems like the most obvious one.
Right, so blood loss anemia. We split it into acute and chronic. Acute hemorrhage is sudden, rapid loss. Think major trauma, bad cuts, blunt force injuries, or surgical complications, guttural pouch mycosis, where fungus erodes an artery.
Right.
That's a nasty one.
Yikes.
Yeah. Or a ruptured uterine artery in a mare after foaling, severe nosebleeds, internal bleeds like a ruptured spleen, or bleeding linked to colic. And initially, right after the bleed starts, the PCV might actually look normal because they lose everything, cells and plasma together.
Oh, okay.
But then as fluid shifts from the tissues into the vessels to try and restore volume, everything gets diluted. That's when you see the PCV and the total protein drop together.
You mentioned guttural pouch mycosis eroding the carotid artery. That sounds terrifyingly specific. How common is something like that?
Thankfully, not super common. But it's absolutely a worst-case scenario that vets need to have on their radar. When it happens, the bleeding is often massive, life-threatening. A severe nosebleed, especially just from one side, that won't stop. That's a major red flag for it. Needs immediate attention.
Got it. Okay, so that's acute. What about the slower, sneakier kind? Chronic blood loss.
Yeah, chronic hemorrhage is that slow, steady, drip, drip, drip over time. Often it's from the gastrointestinal tract. Think gastric ulcers, colonic ulcers, or heavy parasite burdens, especially Strongylosis vulgaris. Bleeding in the urinary tract can cause it too. The key thing with chronic blood loss is that it slowly uses up the body's iron stores.
And that leads to a specific type of anemia, right? Iron deficiency anemia.
Exactly, because iron is absolutely essential for making hemoglobin, the oxygen-carrying part of the red blood cell.
So what happens to the red blood cells when the iron runs low? You mentioned it changes how they look.
It does. They become microcytic, meaning smaller than normal, and hypochromic, meaning paler than normal.
Or because?
Because they don't have enough hemoglobin packed inside them due to the lack of iron. So you get these small, pale cells. Seeing that on a blood smear is a really strong clue pointing towards chronic blood loss causing iron depletion.
Okay, now you mentioned iron deficiency there from chronic loss, but I think we noted later that nutritional iron deficiency is rare. Can you square that circle? Sounds a bit contradictory.
Yeah, that's a great point, and it often causes confusion. You're absolutely right. Primary iron deficiency, like just from the diet, is very rare in horses if they're eating reasonably well. They get plenty from forage. When we talk iron deficiency anemia in horses, it's almost always secondary. It's secondary to that chronic blood loss. They're not lacking iron in their food. They're losing iron faster than they can absorb it because they're constantly losing small amounts of blood.
Okay. The loss is the cause of the deficiency, not the diet itself.
Precisely. The blood loss drains the tank, even if the dietary tap is on.
Makes sense. Okay, so we've covered losing blood. What about the second mechanism when the red blood cells themselves are being destroyed prematurely? Hemolysis.
Right, hemolytic anemia. This is where red blood cells are breaking down, or lysing, way before their normal 150-day lifespan is up. This destruction can happen right inside the blood vessels. That's intravascular hemolysis. When that happens, hemoglobin spills out into the plasma.
So you'd see pinkish plasma.
Yeah, hemoglobinemia, and often it spills into the urine too, causing hemoglobinuria, dark reddish-brown urine. Or the destruction can be extravascular, where damaged cells are pulled out by macrophages, mostly in the spleen and liver. That's often less dramatic, less obvious hemoglobin in the plasma or urine.
And what causes this destruction?
A real mix of things. A big one is immune-mediated hemolytic anemia, IMHA. The horse's own immune system attacks its red cells. Sometimes we don't know why that's primary IMHA. Other times it's secondary, triggered by infections, certain cancers, or even drug reactions, penicillins. Some NSAIDs can do it.
Okay. What else?
Oxidative damage is another major category. If a horse eats something that acts as an oxidant, it damages the red cells. The classic example everyone knows is wilted red maple leaves.
Right. Toxic.
Very toxic. Potent oxidant. Onions, garlic in large amounts. Some older dewormers like phenothiazines can also cause oxidative damage. Then you have infectious causes, pyroplasmosis caused by Thalaria or Babesia parasites transmitted by ticks, and equine infectious anemia, EIA, that's a virus.
So quite a few potential culprits.
Yeah, and others too, like heavy metal toxicity, even some snake bites, or just severe systemic inflammation, sepsis. Signs often include jaundice, yellow gums or eyes, what we call icterus plus fever, that dark urine we mentioned, maybe an enlarged spleen.
Okay, and the third big category. The factory just isn't making enough red blood cells. Decreased production.
Exactly. Non-regenerative anemia. The bone marrow, which is the red blood cell factory, isn't keeping up. And because those equine red cells live so long, this type usually develops really slowly. It can be subtle at first.
What shuts down the factory?
The most common reason by far is something called anemia of chronic disease, or ACD. This happens with long-term inflammatory conditions. Think chronic infections like internal abscesses, ongoing laminitis, inflammatory bowel disease, even some cancers. In these cases, the body kind of hides iron away inside macrophages. It makes iron unavailable for making new red blood cells, even if there's plenty of iron in the body overall. It's an inflammatory response.
Huh. So the iron's there, just locked up.
Pretty much, yeah. Then there's chronic kidney failure. Diseased kidneys don't produce enough erythropoietin, or EPO, which is the hormone that tells the bone marrow to make red cells.
Ah, the signal's missing.
Right. And then you can have direct bone marrow suppression or even aplasia, where the marrow just shuts down. This can be caused by toxins, certain drugs like chloramphenicol, or high doses of some NSAIDs or sulfur antibiotics, severe infections like EIA again, or equine parvovirus hepatitis, or cancer spreading into the marrow.
And nutritional deficiencies, you mentioned they're rare as a primary cause.
Yeah, things like copper, cobalt, B vitamins. Usually horses get enough if their diet is decent. And as we said, pure dietary iron deficiency is almost unheard of. It's nearly always linked back to that chronic blood loss.
Okay, so we have these three broad causes: loss, destruction, poor production. When a horse is anemic, what signs might you actually see? What should someone look out for?
Well, it really depends on how severe it is and what's causing it. Horses are incredibly good at compensating, especially for slow-onset anemia.
So they might not look sick initially.
Exactly. Mild anemia might just show up as slightly reduced performance. But the most classic consistent sign when it gets more significant is pale mucous membranes.
Checking the gums.
Checking the gums, yeah, or inside the eyelids or the vulva on a mare. Instead of being nice and pink, they look pale pink, or even white if it's really severe. Other common signs are just general lethargy, weakness, getting tired easily with exercise. You might also notice a faster heart rate tachycardia or faster breathing tachypnea. The body's trying hard to compensate for less oxygen.
And some signs might point towards a specific type of anemia.
Definitely. Like we said, if you see icterus, that yellow tinge or that really dark urine, you're thinking hemolysis, red cell destruction. Significant weight loss, poor coat, might point towards a chronic disease causing ACD. Signs of colic could suggest internal bleeding.
This brings us to the diagnosis, the detective work. How do we actually pin down anemia in horses? And you mentioned it's kind of unique. What makes it so different?
Okay, this is probably the single most important thing to understand about equine anemia diagnosis. It's the reticulocyte response, or rather the lack of one.
Reticulocytes being the young red blood cells.
Exactly. In dogs, cats, humans, most mammals, when they're anemic and the bone marrow is ramping up production to fix it, it releases these slightly immature red cells, reticulocytes, into the blood. Counting them tells you if the anemia is regenerative, meaning the marrow is responding.
But not in horses.
But not in horses. They just don't release significant numbers of reticulocytes into circulation, even when their bone marrow is working flat out. It's a huge species difference.
Wow. So that standard test for regeneration is basically useless.
Completely useless for that purpose in horses. If you don't know that, you could easily look at blood work from a horse with, say, anemia from recent blood loss where the marrow is responding and mistakenly call it non-regenerative because there are no reticulocytes, sends you down totally the wrong path.
Okay, that is a massive difference. So if you can't use reticulocytes, how do you figure out if the bone marrow is trying to compensate? How do you tell regenerative from non-regenerative in a horse?
We have to use other clues. One of the best ways is sequential monitoring. Tracking the PCV over several days. If you see it starting to rise on its own without a transfusion, that's a really good sign the marrow is kicking in.
So trending it over time.
Yes. We also look really closely at the blood smear under the microscope. We look for subtle signs like anisocytosis. That means variation in the size of the red cells. And maybe some macrocytosis, meaning some cells that are a bit larger than normal. These are the best hints we get from peripheral blood that regeneration is happening. And in really tricky cases or severe non-regenerative anemia where we suspect a marrow problem, the definitive way is to take a bone marrow sample, an aspirate, or a biopsy, and look directly at what the factory is doing.
Okay, so initial confirmation comes from the CBC, the complete blood count.
Yep, the CBC is step one. We look for that low PCV, low red blood cell count, low hemoglobin. Then we look at the indices, FCV, MCH, MCHC. Are the cells normal size, normal color? Or are they small and pale, suggesting that chronic blood loss, iron deficiency? Or maybe large, hinting at regeneration. Are there Heinz bodies suggesting oxidative damage?
And you mentioned total protein earlier. How does that fit in?
PP, or total plasma protein, is super helpful. If both PCV and TP are low, it strongly suggests acute blood loss, where they lost both cells and protein out of the body. If the PCV is low, but the TP is normal or even high, that can mean internal bleeding, where the protein gets reabsorbed. Or it might point toward chronic inflammation, because inflammatory proteins can raise the TP level. It helps differentiate.
So beyond the basic blood work, what other specific tests might you run, depending on what you suspect?
It really depends on the clues from the history, the exam, and that initial blood work. A good history is vital. Any trauma, weird meds, travel history for infectious diseases,
Right.
access to dodgy plants.
Right.
Then, if we suspect blood loss, maybe a fecal occult blood test to check for hidden blood in the manure, endoscopy, scoping the stomach or colon to look for ulcers, maybe an abdominal ultrasound if we suspect internal bleeding, or checking urine for blood, a coagulation panel if we think there's a clotting problem.
And for hemolysis?
For hemolysis, we'd look at the plasma color, run a Coombs test if we suspect immune-mediated destruction, carefully examine the blood smear again for parasites or signs of oxidative damage like Heinz bodies, maybe run PCR tests for specific infections like paroplasmosis or EIA, or even toxicology screens if poisoning is suspected.
And if it looks like decreased production?
Then the focus shifts to finding that underlying cause. Diagnosing and treating whatever chronic inflammatory process might be going on, looking for high inflammatory markers like fibrinogen or SAA. Definitely running an EIA Coggins test is crucial. And as I said, if it's severe and unexplained, that bone marrow biopsy becomes really important.
Okay, so we've done the detective work, we know it's anemia, and hopefully we have a good idea why. What's the game plan for treatment?
The absolute number one priority is always to identify and treat or eliminate the underlying cause. You can support the horse all you want, but if you don't fix the root problem, the anemia will likely persist or come back. Beyond that, treatment involves good supportive care, rest, nutrition, minimizing stress. We need to make sure the horse's tissues are getting enough oxygen, so minimizing demands is key. And then in critical situations, blood transfusions.
Okay, transfusions. When are they really needed and what's involved? Is it like in humans?
They're generally reserved for pretty severe life-threatening cases, usually when the PCV drops really low, say below 12%, maybe even a bit higher, like 15–20%, if the horse became anemic very rapidly and is unstable, showing signs of shock. And yes, similar principles to humans apply. Cross-matching blood between the donor and the recipient is really strongly recommended, especially if the horse has had a transfusion before or if it's a mare that's been pregnant. They can develop antibodies.
What if you can't cross-match in an emergency?
It's not ideal, but sometimes necessary. We try to find a donor known to be negative for the most common reactive blood types, A and Qua. If that's not possible, sometimes a healthy gelding of the same breed who's never had a transfusion is used as a universal donor of sorts, but there's always a risk of reaction without a cross-match.
Okay. And what about general care for these anemic horses?
Supportive care is crucial. Strict stall rest is usually needed for horses that are weak or have a very low PCV, say under 15%, to reduce their oxygen needs. Good quality nutrition is important for recovery. And obviously making sure they have zero access to any potential toxins like those red maple leaves. Also, transporting a severely anemic horse can be really risky. It can push them over the edge. So stabilizing them first, if possible, is generally preferred.
Right. And then what about specific treatments for each type of anemia?
Okay, so for blood loss, priority one is stop the bleeding. Surgical repair, pressure bandages, cautery if needed. Fluid therapy 5E fluids are critical to restore blood volume and support circulation. Oral iron supplements might be given, but only if iron deficiency is actually confirmed through testing, usually after chronic blood loss. And this is really important. Injectable iron is generally not recommended for horses.
Why not? Seems like it would work faster.
Because true dietary iron deficiency is so rare, and horses are surprisingly susceptible to severe, even fatal anaphylactic reactions to injectable iron products. The risks usually outweigh the benefits unless there's a very specific, proven need, which is uncommon.
Good to know. Okay, what about treating hemolysis?
First step, remove the cause immediately. Stop the offending drug, get the horse away from toxic plants. If it's IMHA, the main treatment is immunosuppression, usually starting with corticosteroids like dexamethasone or prednisolone. If those don't work, other immunosuppressive drugs might be added. If it's an infection like pyroplasmosis, then specific antiparasitic drugs are needed. Fluid therapy is often vital, especially if there's hemoglobinuria, to help protect the kidneys. Sometimes antioxidants like vitamin E are given too.
And finally, for decreased production.
Here, it's all about treating the underlying problem. If it's anemia of chronic disease, you have to manage that chronic inflammation, drain the abscess, treat the gut disease, manage the laminitis. If it's kidney failure, supportive care for the kidneys, maybe trying those EPO-stimulating drugs, but being aware they might develop antibodies to them over time. And sadly for EIA, there's no treatment. It's either lifelong, strict quarantine, or euthanasia, depending on regulations and the situation.
What's the typical outlook, the prognosis for these horses?
It's hugely variable, as you'd expect given the range of causes.
Prognosis can be good to excellent if it's, say, acute blood loss that's easily stopped and treated, or mild ACD where the underlying issue is managed. It becomes more guarded for severe hemolytic anemias, especially IMHA, which can be tough to control, or for chronic non-regenerative anemias like severe kidney failure. And unfortunately, the prognosis is often poor to grave for things like uncontrollable hemorrhage, severe bone marrow failure, or advanced EIA. Consistent monitoring, tracking that PCV and TP during and after treatment is absolutely crucial to see how the horse is responding and adjust the plan as needed.
Wow. Okay, so we've really covered a lot of ground here. It's clear that understanding equine anemia isn't just about knowing the symptom, but really digging into those mechanisms: loss, destruction, production, and especially grappling with those unique diagnostic challenges, like the whole reticulocyte situation in horses. Absolutely. And maybe a final thought for listeners. Given everything we've discussed, the diverse causes, the diagnostic curveballs, how does thinking about the mechanism behind the anemia, rather than just seeing anemia as the problem, fundamentally change how you might approach or think about a horse that just seems a bit off, maybe lethargic with pale gums?
That's a great question. It shifts the focus from just the symptom to the why, doesn't it? Understanding these details hopefully empowers you, the listener, to ask better questions, work closely with your vet, and really get to the bottom of what's going on. We hope this deep dive has been helpful. Keep learning, keep asking questions. That knowledge is powerful for your horse's health.